Hey, everybody, welcome back to the Healthy, Wealthy, and Smart podcast. I am your host, Karen Litzy, the owner of Karen Litzy Physical Therapy located in New York City. And on today's episode, we are going to be talking about gait analysis, which is very, very exciting for physical therapists and maybe a little unknown for everyone else. But gait analysis is how you walk. So it's really, really important. And we're going to talk about how that changes as you get older, how to analyze it, and what it all means. So, joining me today, I have Pat Tarnowski, also a physical therapist. He is the chief commercial officer at One Step, spearheading the real life gait analysis company's U.S. market expansion through strategic provider partnerships. With over 2 decades of experience spanning health plans, health systems, medical devices, startups, and digital care delivery, he has been driving innovation across the healthcare landscape. A published clinical researcher, National Science Foundation grant reviewer, and mentor for healthcare innovation programs, Pat brings deep expertise and is passionate about advancing innovative care solutions that improve patient outcomes. So, Pat, welcome to the podcast.
It's Karen. It's great to be here. I've been looking forward to this conversation for quite a while.
Yeah. And like I said, we're going to be talking about gait analysis. But before we get into that, can you give the listeners a little bit more about your background? Like I said, you are a physical therapist. So, how
Mhm.
did you? I mean, I'm going to go out on a limb here and say when you first graduated, you were working in patient care, maybe. And
Yep,
so,
you
how
got it.
did you go from that to where you are now? And what is your, are you passionate about gait analysis?
Oh my gosh. Yes. So one, you're right. I started off like most of us do in the clinical space, and uh, absolutely loved what we did. Loved the patient care. Loved the opportunity to work with patients really when they're at their most exposed and vulnerable time, when things are not good in their world. And so the opportunity to work with them, the improvement and play hopefully a meaningful role in their return to activity and however we define activity, sport, work, parenting or grandparenting, whatever it is, was such a treat. What I in my practice, and this is the part I don't really know how it happened, I just found this love for understanding the biomechanics of the lower extremity and especially foot and ankle. And what I saw was there was just this gap. I think there were not a lot of therapists who really chose to focus on life below the malleoli. For those non-clinicians, there's a clinical joke in there somewhere.
Mhm.
Um, and what we also learned was, so many people with problems in their foot and their ankle, you could make a very meaningful improvement in their quality of life by addressing the biomechanics, the strength, shoes, devices, what have you. And so had the opportunity to do a lot of teaching around about foot and ankle around the country, had a few academic appointments in that area, and then realized that I kind of had even a deeper affinity for the business of our business, and thought, oh, if I bet we could start to have a greater impact if I understood more of the business and mechanics of how it works. So I took a bit of a turn, did an MBA, and then made a shift into the medical device world. Um, and within medical device, again, started to understand how new products are introduced and new technologies are introduced, what's required from a regulatory perspective, a legal perspective, but maybe most importantly, what's required from a patient and provider perspective to see technologies actually move from the bench to the bedside. So I spent many years in there and had lots of opportunities to work with centers of excellence around the country, whether it was in orthopedics or neurology or wound care or geriatrics or pediatrics. And so actually, it was this incredible learning lab to keep enhancing my knowledge of our profession. And was traveling nonstop, and a bit of the personal story, my kids were very young and I just couldn't continue to travel anymore, so I left and um, went back into clinical care, and with a colleague opened a practice here in the Twin Cities that focused on occupational medicine, and we scaled that up and had some good success with that practice. And then from there said, had this opportunity to join and lead the rehabilitation service line for a very large health system here in Minnesota. And again, what a amazing learning opportunity to be surrounded by just incredible physicians and nurses and PT, OT, speech, rehabilitation psychologists, and start to get a better appreciation for not only the acute musculoskeletal side of the world, but also the rehab side. So we provided rehab into 11 hospitals and 40 outpatient locations and two acute rehab units. So really started to get a much better feel for acute to post-acute. And just it was just an amazing gift and blessing to be in that time. And then took a bit of a shift onto the other side of our equation to understand how bills get paid. So I
Hmm.
went to work on the health plan side and learned so much about how providers think about medicine. We actually are very aligned, payers and providers, in terms of we want better quality, we want good cost of care, and we want good patient or member experience. It's just that each side has some different levers to pull on how
Hmm.
to achieve those goals. Um, but while working within one of the health plans, and this will circle us back into the conversation more today about gait and mobility. One of the leadership hats that I was fortunate enough to wear was oversight for a portfolio of digital health products that spanned from mental health to musculoskeletal to employee assistance and cardiometabolic and maternity. So really started to see how these tools can expand care, create more access to care, and enhance the delivery between the relationship between the patient and the provider. So, kind of a long story into uh, after leaving that position and starting my own consulting practice, was connected to many different technologies that focused on things like gait and mobility, and how to make that more accessible
Hmm.
to the community at large, whether they're providers, payers, or patients.
Yeah. So it sounds like you had a really sort of robust career thus far. So
Mhm.
now,
Yeah, hopefully
how,
it's not done yet.
yeah, yeah. And so I can see how that kind of love of foot and ankle and biomechanics certainly leads into gait evaluation,
Mhm.
right? So if as the physical therapist,
Mm.
what do you look for? And this is a big question, and I'm
Right.
sure this is like a 3 day course, but if you can condense a 3 day course down into like a 5 minute answer to my question, um,
Mhm.
but when we're looking at gait analysis, in your opinion, what are the biggest things to look for when it comes to gait? And I know like it's going to depend on the patient and the diagnosis and what the patient's goals are, et cetera, right? But
Right.
have you found, um, whether maybe it's special tests or it's just looking at gait, that tends to give sort of the biggest bang for your buck when it then comes to gait retraining?
Right. Yeah. So maybe let's start with a bit of a an evidence-based perspective.
Mm-hmm.
So what the evidence about PTs doing observational gait analysis tells us, and that's frankly, again, that's what most of us have, right? We don't have
Right.
fancy gait labs in our practice.
Correct.
So we have our eyes. So what we've learned about PTs doing observational gait analysis is we're best with binary decisions, meaning it is or it isn't. It's present or it's not present. It's normal, and I'll use that in air quotes, normal or abnormal.
Yeah.
So so our ability to say, well, maybe, or it's kind of in the middle, we're not as good at that.
Mm-hmm.
So the other thing we that the data tells us about PTs is we're best when we're looking at how somebody is walking in front of us across, because we can see angles like how is the knee moving, how is the foot moving, or the foot and the ankle. Um, we're second best at watching them from the front or the back to see how they
Mm-hmm.
move, in or out, being sort of generic in terminology, varus or valgus. What we're least effective at picking up is understanding how somebody's leg is rotating,
Mm-hmm.
right? So if we start with those kinds of uh, guidelines, again, let's let the evidence guide our inform
Mm-hmm.
and guide our practice. The things that we're looking for are 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 what we're seeing with our patients ambulating, are they normal? Is the timing happening correctly? Is the sequencing happening correctly? So we start there, and we're looking for big things. Let's not look for,
Right.
is it 3 degrees, 4 degrees? Because we're just not good enough to pick that up, right?
You can't, yeah, you can't pick
You
that up
can't you
just by
can't see it.
looking. Mm-mm.
Yeah. So let's look for big things. Do we see if we're watching from the side, is there enough motion in the ankle? If we have 10 degrees of dorsiflexion, then you have enough motion for, again, quote, normal gait.
Mm-hmm.
Do we see the knee extending or flexing? So many, let's put a patient profile here. Let's think about a patient who might have had a total knee replacement. So many of these patients who don't quite have enough terminal extension, either because they didn't get their motion back, it's
Mm-hmm.
a tissue issue, or they don't have the neuromuscular control over the quadriceps. Well, we can see if that patient is putting a heel on the ground with their knee flexed.
Mm-hmm.
And if so, boy, then we need to have our understanding of biomechanics rooted in the application of these, finding again the big stuff. So if we could say, boy, that patient can't totally straighten out their knee when their foot's hitting the ground, well, that patient's now walking with a functionally shortened limb.
Mm-hmm.
What do we know what happens in a functionally short limb? Well, the hips might start to do this, or I might find some other compensations. And we're really good at understanding the compensations. But I think we need to start with, again, what is it that we can see? What are the big things? And then understanding the implications of the either too much of something or not enough of something.
Mm-hmm. Mm-hmm.
So where do you start? When I used to teach an awful lot of foot and ankle, folks would say, do you start at the bottom and look up? Do you start at the top and look down? And the answer is yes. But find a system where you have some consistency. And I think if we start there, that that gets us onto our, no pun intended, our next steps of how to look at how somebody is moving.
Right. And I think I really like what you just said. Like, it doesn't matter which way you're looking at as long as you're doing it consistently, because we do
Mhm.
want to have some intra-rater reliability.
Yeah, right,
Right.
right, right.
And so if you sort of have your own system and this is how you look at things every single time, great. At least there's some intra rater reliability to that.
Yeah, right. But and then, with that, Karen, I think we have to always uh, understand what is our patient telling us, because we can go find things, and we've all done this in the shopping mall, right? Or when we're sitting
Totally.
having coffee, right? It's
Yeah.
an occupational hazard. In fact, my daughter is a third year PT student. She's graduating in May, um, and she's now telling me that, we were at combined sections in Houston a couple of
Mm-hmm.
weeks ago, and as we're walking around, she's saying, "Oh, I can see what that is. And that is." We all tend to
I know
look for
you're like, you're
problems.
sitting there and you're like, total knee replacement, hip replacement,
I could see that.
ACL,
Yeah, I could see it all.
ankle twist. You're
Yeah,
making up these hypotheses in your head, whether they're right or not.
right. So let's correlate that to the reason that our
Yeah.
patients have come to see us, right? So I think
Yeah.
those are all important. And then I think from there, so now we know what our patients have presented with. We've identified mechanical issues in gait that we'd say something just doesn't look right.
Mm-hmm.
And then we start to correlate that with, okay, let's come back to that total knee patient. Not enough extension. Well, then let's go look at the knee and understand, can I get that motion back? Is it a motor control issue, or is it a joint mobility
Mm-hmm.
limitation? Um, when we see that the pelvis is dropping from the short limb, well, we all learned what a Trendelenburg gait is. So let's start to address, how do we address gluteus medius and then the hip rotation? So gait analysis for analysis sake, I think is interesting, but without a correlation to the patient presentation and a now what do we do with it,
Mm-hmm.
it's it's just information.
Right. It's
So
just data
data for
that's not
data's sake doesn't help.
exactly. It's just data that's just there,
Exactly. Right,
which
right, right.
okay, but what are you going to do with it? And like you
Mhm.
said, I really like how you said like this really we needed to correlate to the patient
Right.
and their goals and what they're coming in to see you for.
Yeah, exactly. Yeah, because we can start, and we've all done this. We can start addressing something or making up outcomes
Mm-hmm.
or goals
Terrible.
for the
Yeah.
patient that
Yeah.
doesn't necessarily, we've had the patient say, well, that's great, but really what I want to do is this.
Yeah.
And
Like
so it, you know,
I don't need to walk a mile. You know, I just
yeah,
need to do
exactly.
XYZ.
Right, right. My goal is really to be able to play with my grandkid,
Right.
you know? Yeah,
Exactly.
yeah.
Exactly. Exactly. So, all right. So let's say you are working with a patient. Again, we'll go with this total knee replacement patient just to have
Mhm.
an avatar
Yeah,
for people
right.
to think about. So you've done your sort of visual gait analysis. You've used whichever kind of organizational structure you want to use. So let's say you found something, you're not sure, you want to take a closer look. Would you suggest videoing it in slow motion or slowing it down? Like, where can we go from just visual? What happens next? What can we do next?
Right. So certainly, the advent of these, right?
Yeah,
We all now have a video motion capture in our hands
right,
or on our iPads or whatever we're using to document.
right.
So I think it certainly brings it can slow something down. It can help us look at more precisely at a particular joint or a joint angle, um, which we could use to perhaps further inform a treatment plan.
Mm-hmm.
But again, I think sometimes those are a bit limiting, or they may bias us. We
Mm-hmm.
might see something here and we might say, well, because of that, I better go fix this. But that might not be the functional.
Mm-hmm.
So so I'm not suggesting don't use those tools because it is very hard. It's very hard to do analysis, like because the 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 speed and the joint is moving through a gait cycle. Again, very hard to pick up with levels of precision with just the naked eye.
Mm-hmm.
So if it's a tool that helps you or helps the provider make a more informed decision about where to go with the treatment plan, I think that's terrific.
Mm-hmm.
But I think it's perhaps equally as important to start correlating that to function. So again, let's think of that total knee patient.
Yeah.
So we see that there's limitations in extension, and we'll just say they don't have 10 degrees of extension. This patient has a shorter leg. Let's functionally shorter leg now. Let's let's see how they're moving functionally. So how do you do on a step up, step down? Do you see that sort of classic valgus collapse
Mm-hmm.
because of a shorter leg? I'm going to find a compensation. Am I finding that there's just a significant asymmetry in the way they're functioning? Those are the pieces that I think become more confirmatory
Mm-hmm.
and then help it inform what the treatment plan would be. So with this particular knee patient, the avatar we're talking about here, if we understand that this patient can't straighten their knee because it's stuck, then let's make it unstuck. Let's help it
Mm-hmm.
to move better. And we have all the tools. Who better than us?
Right.
Manual therapy tools, soft tissue tools, dynamic splinting, whatever it would be to help restore that. If it's that there's active or there's passive motion, but not enough active control, who better than us to help them regain that terminal knee extension actively? And when we're doing that, well, now we understand what has to happen at the hip, the pelvis to control the more proximal chain,
Mm-hmm.
right? So I think that tools like video motion capture could help us, but I think more importantly, and again, sometimes practically, given the pressures of getting patients through the clinic and the
Right.
productivity expectations we all have,
Right.
to put our clinical thinking caps on. The more of this that we do and the more we understand what the norms look like. If you understand the norms, the abnormals are a whole lot easier to identify.
Mm-hmm.
And if you understand the abnorms and basic biomechanics and muscle function concentrically and eccentrically, open chain, closed chain, then the treatment plans start to define themselves pretty well.
Mm-hmm. Yeah.
And it gives us the chance to follow the evidence.
Right. And so as you're looking at gait analysis, it's not something that's done just on initial exam and then forget about it.
No, no, and I
Right.
think we do this every time. Every time someone comes into our clinic,
Right.
we watch them come across the parking lot if we happen to have a window, right? And
Mm-hmm.
how do they move when they're not being watched?
Mm.
And then how do they move when they're in the clinic?
Mm-hmm.
And is our intervention making a difference? Are we seeing the
Right.
improvement? And then correlating that to what the patient's telling us. How did you do? Did you walk further? Did your stairs get better? Are you feeling this and this and this?
Right.
So it's an ongoing process for us. So it's not just beginning and just end. We should be assessing all the time to see what the impact of our intervention is.
And do you use any, whether it be an outcome measure or anything like that, like a standardized outcome measure that you can share with the listeners that you use with these patients through gait analysis, whether it's a
Yeah.
standardized measure, test, etc.?
Yeah, the tool that I used most routinely was the LEFS, the lower extremity functional scale. Public domain helps us understand the patient's perspective on how they are moving.
Mm-hmm.
Um, Easy, simple, and to be able to use that periodically during their treatment.
Mm-hmm.
Yeah, I think it's just simple. There are many scales and tools out there. It's and again, I think it kind of goes back to how do you choose where to start your assessment, top to bottom, bottom up.
Mm-hmm.
Just have a tool that you're using consistently, know what the parameters of the tool are, know when to apply it, know what it means. Um, a bit of a pet peeve is that we're pretty good at capturing outcomes data, but I don't know that we actually use it to inform clinical practice all the time, right?
Mm-hmm.
So there's a lot of initial and discharge outcome measures, but I think we have some opportunity to get more informed to use that to drive our own personal practices, our organizational practices, and then start to be able to correlate comorbidities from an EMR or what are we seeing from these
Mm-hmm.
particular, from a particular physician and particular diagnosis. So there's so much power in these patient-reported outcomes.
100%. And how about, this may be a little bit more difficult. What about patient confidence? How does that play into gait analysis? So for example, I have a patient who at the moment is not very confident in her walking and in her abilities for a variety of reasons. Right. And
Right.
I'm sure you've seen patients, whether it's pre surgical, post surgical, neurological, someone who had a stroke, etc., MS, Parkinson's. And from a physical standpoint, not bad. From a confidence psychological standpoint around walking, whether it be fear of falling, fear of a knee buckling, et cetera, et
Mhm.
cetera. So, how do you work with that patient?
So let's move from say a total knee to an aging patient or a
Yeah.
senior, right? So you mentioned fear of falling, right? So let's
Mm-hmm.
let's let's focus there for a moment. Um, so certainly falls have become a just a horrific issue for not only the US but worldwide. And we have data now that says it's estimating the cost to the US healthcare system in the very near future due to falls will be about $100 billion. So it's those aren't just billions of dollars; those are lots of lives, right? And
Mm-hmm.
lots of people. Not only those that fell, but their family, their caregivers, their care team. Um,
Absolutely.
it's a global issue in every sense of the word. So if we start to look at an aging, um, we'll call him a patient, a patient who is aging, we start to notice changes over time in a normal gait cycle, right? And these are things that we could geek out clinically, but
Yeah.
but we see it. Um, we see speed dropping.
Mm-hmm.
We see range of motion dropping. We see symmetries between the right leg and the left leg changing. We see things like how far their feet are spread apart when they're
Mm-hmm.
walking
Or the
change,
the
and we see a
side to side
tilt or
lean.
exactly.
Yeah.
Yes. So we know that range of motion changes, speed changes, intensity changes, endurance changes, and with that, so too may confidence. And it's a really it's a very challenging um, thing to be able to identify with the naked eye.
Mm-hmm.
Because let's come back to just speed for a moment. So you've seen, and many of our colleagues that are listening to this have seen or heard, gait and gait speed are the new sixth vital sign,
Mm-hmm.
right? And it's true. Gait is such an important biomarker of health. Um, so if we see gait speed, we'll just keep using this as an example.
Yeah.
If our gait speed drops below zero point 0.8 meters per second,
Mm-hmm.
that's a bit of the magic cutoff, right? If it drops even zero point 0.1 meter per second down to zero point 0.7, your risk of falling or that patient's risk of falling goes up 7%. Or that same zero point 0.1 meter per second change, the mortality risk is up 12%. The risk of cardiovascular disease is up 8%,
Mm-hmm.
as is risk of cognitive decline. So, so we think of that just the importance of zero point 0.1 meter per second. And as professionals, we just said it's very hard for us to identify changes in gait just observationally.
Mm-hmm.
How think of the importance of that vital sign that we now potentially missed.
Mm-hmm.
So this idea of gait and gait speed as a vital sign with equal power and representation of, say, a heart rate, a blood pressure, respiration, temperature. We those are measured every time someone is in to see their doctor, and hopefully more and more into our physical therapy clinics.
Mm-hmm.
Uh, if we're not measuring this vital sign of gait and gait speed and symmetries and asymmetries, we're missing really, really important information
Yeah.
that could inform our clinical care. So if we keep that, we're grounded in this deep body of scientific literature that supports that, it's no wonder that we see patients that have fear of falling scores that are high if their
Mm-hmm.
confidence is down.
Mm-hmm. Yeah.
And oftentimes they don't really appreciate why. I just don't feel steady. I don't feel stable. I'm afraid of this. And then think of the societal impact on this, where we talk about in an aging population, social isolation. And COVID certainly pulled back the curtain on social
Yes.
isolation, not only in younger, but even more so in a senior and aging population.
Absolutely.
So if I'm afraid, if I don't have confidence to move, it's another reason for me to pull back and not participate.
Mm-hmm.
And when I'm not participating, all the bad things that happen with social isolation. So this idea of gait and confidence and the ability to participate in life is such an important thing. And that's part of the, I think, both the fascination and my personal passion around gait as an important indicator of health. And who better to be able to identify these things and develop strategies for our patients than our colleagues as PTs?
Yeah. And when you spoke about the changes in gait speed, I think that's really powerful. What is the best way for one to measure gait speed? So we don't have a fancy gait lab or anything like that. We have our clinic. I'm in New York City. Sometimes we don't have a whole heck of a lot of space.
Right,
But what
right.
is the best way to measure that gait speed so that, especially with our older adults, it could be something that we're checking in with? Maybe it's once every couple of months or something like that.
Right. So, our very low tech way, pace off a certain distance, in your clinic, put some tape here, some tape there, know what that distance is, measure the amount of time it took someone to cover that distance, and then do the math to calculate gait speed. Pretty simple. I'm guessing ChatGPT could do that calculation very easily for us all, right?
Right.
Um, but so it's a good baseline. It's a good mid mid treatment
Mm-hmm.
plan and discharge.
Mm-hmm.
But one of our challenges there is it's a point in time, and it's a point in time when that patient knows that they're being observed.
Right. And so are they
How are they
walking
functioning?
faster? Are they, because you're saying to them, we're going to measure
Exactly.
your gait speed. Well, if
Right.
someone told me that, I would be like huffing it down, you know?
Yeah, absolutely it would. And then what if we add in a challenge like dual task?
Mm,
Well, we know that changes things. right?
Yes. Yes.
Um, so the both the I'm not saying we shouldn't measure, right? Let's get baseline. It's
Yes.
important for our documentation. It's important for our communication with our patients and their family and caregivers. But let's also recognize the potential limitation in that and understand that we have the gift of being with our patients for just a few minutes of their week in
Mm-hmm.
totality.
Mm-hmm.
So what's happening in the rest of their environment?
Right.
So that's where I get a bit excited about the opportunity to start looking at how might somebody be functioning in their real world and use that to help inform even more clinical decision making.
Yeah.
So
Yeah. And I
yeah,
think it's kind of a nice segue now to talk about One Step. So as I mentioned at the top of the podcast, you're the chief commercial officer at One Step. So how does One Step work to bridge that gap between the time we're seeing a patient, which, like you said, maybe it's a half an hour a week, maybe it's an hour, maybe it's every other week.
right. Yeah.
So what happens the rest of the time, and how does One Step, no pun intended, step in
Right.
to kind of fill up that gap and give us some more data?
Yeah. So what we've been able to do at One Step, again, deeply entrenched in the idea and the importance of gait as an important indicator of health. So what we've been able to do is harness the power of the motion sensors in any smartphone. And we see this every day when we're on the street trying to navigate, by turning right or left. Our
Mm-hmm.
phone moves with us, right?
Mm-hmm.
So there are some very intricate motion sensors and gyros inside of the phone. They're capturing information each time we move. What we've been able to do is take that information, all this raw data, and translate it into clinically validated standardized gait measures.
Mm-hmm.
And we can do it both actively. So when you talk about the patient in the clinic, simply by dropping a phone with a one-step app on loaded onto it and having that patient walk about 20 steps, we've completed the full gait analysis with temporal spatial parameters, including those things like gait speed and the symmetry between sides, the sway, all of those things we just talked about. And so that helps clinicians make more informed clinical decisions about the
Mm-hmm.
intervention. Then we can layer on top of that things that we do every day in the clinic: a timed up and go, a sit to stand, a functional reach, dual task walking, cat
Mm-hmm.
sib, all with simply the phone in a pocket. And then we translate those into things like fall risk. So patient reported outcome measures, standardized tests, gait data. For the first time, we've been able to close the gap and create one aggregate score around fall risk. We
Mm.
can do that same thing now. We understand, that we've got more than 10 billion gait cycles analyzed.
Wow.
So we
It's a
now
lot. That's a lot
know,
of gait.
yeah. So we now know that patient, that total knee patient, we can see within 2 or 3 days if they're on the expected rehab trajectory and
Mm.
bring that back to the provider to say, Mrs. Jones is not quite where she needs to be. In fact, a couple of years ago with some of our research partners from Mount Sinai, we were presenting at combined sections case studies where patients that were 2 days post total hip were not moving as expected, got them back to the surgeon who took films and found there was a periprosthetic fracture that required an additional plating just
Ah,
based on how they're moving.
yeah.
So it's a tool to be able to capture in the clinic. But back to your question about how do we monitor in their natural environment?
Mm-hmm.
Well, now a patient can take that with them, have the phone in a pocket or a pouch, and anytime they're walking in their natural environment,
Mm-hmm.
we're capturing data, bringing that back to the provider, and we can start to see the differences between how do they function when they're being observed, how do they function in their real world, and identify, hey, your intervention is working. They are indeed getting better, or they have been working and now something has changed. They're
Mm.
dropping off,
Mm-hmm.
or they've been at high risk and now they're no longer at risk. So it gets exciting to think about the work that we do as clinicians, and for years we've spent time talking to our patients on the phone, texting, emailing, whatever it is. Now we actually have the ability to monitor their true functional status,
Mm-hmm.
monitor this important vital sign, in their real world environment and bring that back to providers. And it's having a profound impact.
Yeah, it sounds like it would make the provider's life a little bit easier. Um,
Hmm.
and so when you were talking about like the tug test and things like that, all of that is in the app. The person
Yeah.
just so you don't have to like sit with your stopwatch and all that.
Nope.
Ugh, luxury. Um, luxury.
Right.
Uh,
Right.
because these are those little things like as a practitioner, people might not think like, oh, whatever, it's just a test, just so, they can put it in their pocket and do it. But it's like, no, you don't understand. Like it takes time out of a session I mean, obviously you still have to measure off the distance and everything, but
Right.
it takes time to get everything set up, to have your start, to be, all this stuff makes anything that you can do to save, even if it's saving like 3, 4 minutes. Like, I mean, I see
Right.
patients for an hour, so it's a little different.
Hmm.
But if you're only seeing patients for 20 minutes, man, those 3 to 5
3 or 4
minutes
minutes
make
is a
a
big deal.
big deal. Yeah, it makes a
Right.
big
Right.
difference. So, and when I say like, oh, that's luxury, like for a therapist, like a practicing therapist, that is like it's a luxury.
Right. And where this has been fun, not only from a clinical perspective, where our partners that are licensing our platform, the falls are down on average, Karen, 20%,
Wow, it's
because
amazing.
we're able to proactively identify where there's risk and give
Mm-hmm.
providers the tool to be able to say, here's objectively what's creating the
Right,
risk.
right.
Um, uh, so it's giving our providers the opportunity to be able to even post discharge monitor that patient and see that
Mm.
I know when you left the clinic, you were here. It's been 3 months, 6 months, and we're seeing a decline. Are you okay? Well, maybe we should bring you back in. So,
Mm-hmm.
chance, not only good care, but an opportunity to re-engage that same patient. And then what's been fun to work with our providers is to get to the point where we write the progress note. Here's all the objective data. With one click, the note is written in a way that it's written for documentation, for defensibility.
Right.
This speed means this means this. So again, a time saving for the providers.
Love it. We love to save time and we love to
Amen.
not have to spend an hour at the end of the day doing all our notes.
You got
Um,
it. Yeah.
that's amazing. Now, where can people find more information about One Step if they want to check it out?
So our website is a great resource. It's onestep.co, no M on there,
Mm-hmm.
.co, or they can certainly reach out to me on LinkedIn or email me directly, pat@onestep.co.
Perfect. And just so everyone knows, we will have links to everything in the show notes. So, regardless of where you are listening to this podcast, if you just scroll down a little bit, you'll see the show notes and you scroll down a little bit more. There's a tab that says resources from this episode, and all of those resources will be right there. So, the website, your LinkedIn, and if I mean, very brave to put your email out there, but we'll put that on there as well. So before we wrap things up here, what are the big takeaways that you want the audience to get from our discussion today?
I think it comes back to where we began. As therapists, as wellness practitioners, as anybody who's involved in the pursuit of health, personally or for the people we're privileged enough to serve, our mobility is such an important indicator of health, and we have to pay equally as much attention to the measures, the metrics, the data around gait and mobility as we do with these other vital signs, and continue to pursue these, the opportunities to help our patients move better, to keep ourselves better, to do all of the things that keep us moving and mobile. And I can't even imagine who better to do this than our colleagues that are physical therapists.
I couldn't agree more. And now, before we end, I have one last question. It's one I ask everyone. And knowing where you are now in your life and career, I think this will be an interesting answer. Um, what advice would you give to your 20-year-old self?
Just to remain relentlessly curious,
Oh,
to keep asking questions, and to keep the the opportunities for continued personal growth, professional growth are limitless. But I think there's a discipline of just being curious and being okay saying, I don't know. and asking questions, to call Karen and say, I've never met you before. Could we talk about something? I've got a question for you. To just know that I think most people are willing to help. Most people are willing to engage in conversation. Lean into that, even though it might be uncomfortable. Lean into it and just be curious and enjoy it.
I couldn't agree more. And I don't know if I agree with people calling me, but maybe they can call you instead.
They can call me instead. Yes.
They can call you instead. And
Happy to.
I think that's great advice. And Pat, thank you so much for coming on the podcast. This was great. Again, if you want more information on One Step, it's onestep.co, no M at the end. Everything will be in the show notes. So, Pat, thanks so much for coming on.
Aaron, thank you so much. What a fun conversation.
It was my pleasure. Everyone, thanks so much for tuning in. Have a great couple of days and stay healthy, wealthy, and smart.